Life-threatening infections such as infective endocarditis are increasing simultaneously with the injection drug use epidemic in West Virginia. While overdose is the leading cause of death, infections are among the most likely reason for hospitalizations in IV drug users. Admissions for infective endocarditis in West Virginia increased by 681% over 5 years, primarily attributable to injection drug use. This has led to significant costs and ethical questions for medical professionals and shows the urgent need for both prevention efforts and specialized strategies to improve outcomes. Brad is a 36-year-old male who presents to the ER complaining of night sweats, shortness of breath, a cough, and painful spots on his toes. He appears malnourished and disheveled with dirty, tattered clothing. The night sweat, shortness of breath, and cough have persisted for about a week, and he notices the spots on his toes 2 days ago. Brad was accompanied by his mother, whom he stays with when he's not on the streets. His mother stated that Brad showed up late last night begging to sleep in a warm bed because he was so sick. Brad's mother said that he was born with congenital aortic stenosis and had a valve replacement surgery before his first birthday. Brad has a 15-year history of IV substance abuse that began after he injured his back working construction. He hasn't been able to hold down a job in the last 5 years and has been living mostly on the streets since then. He spent a few nights in jail about a month ago after being picked up for possession. He received his latest tattoo while he was there. Brad states he hasn't received proper medical or dental care in years. Upon inspection, Roth spots were noted in Brad's eyes, which are retinal hemorrhages caused by emboli. On his hands, we can see splinter hemorrhages, which are red streaks under his nail beds. The palms of his hands show Janeway lesions, which are red, painless spots on the palms of hands or soles of feet. And the painful spots on his toes that he complained about were Osler nodes, which are red, painful nodes on the pads of fingers and toes. His temperature was 102 degrees Fahrenheit, heart rate 108. Blood cultures were performed because they can detect a bacterial infection. Echocardiography was ordered because it can reveal inflamed heart layers. Brad's blood cultures were positive for Staphylococcus aureus. His echocardiography showed mitral and aortic valve vegetations. His white blood cell count was 17,000, which can be indicative of a bacterial infection. His ESR was 22 and his CRP was 11. Elevated ESR and CRP indicate inflammation in the body. Based on Brad's clinical manifestations, positive blood cultures, and the results of his echocardiography, Brad was diagnosed with infective endocarditis. Infective endocarditis is a microbial infection of the endocardium of the heart. A deformity or injury leads to the accumulation of fibrin and platelets on the endocardium, which leads to clot formation. Infectious organisms such as staphylococci invade the clot and endocardial lesion. Infection most frequently results in platelets, fibrin, blood cells, and microorganisms that cluster as vegetation. Heart failure is the most frequent complication of infective endocarditis. You can also see intercardiac abscesses, systemic embolizations, or the infection may not respond to medication. Antibiotic therapy is the primary therapy for infective endocarditis. IV antibiotics are usually administered for 4 to 6 weeks. Penicillin, ceftriaxone, amoxicillin, vancomycin, gentamicin, oxacillin, nafcillin, Rifampicin are all antibiotic options, but the choice depends on results of blood cultures as well as patient consideration. Serum levels of antibiotic in blood cultures are monitored to gauge the effectiveness of this therapy. Bed rest is also crucial. Venous thromboembolism prophylaxis. Some consults that may be considered for infective endocarditis include cardiology services, which can be consulted to manage cardiac dysfunction. Infectious disease services can be consulted to manage infection. Physical therapy may be consulted to increase the client's level of activity. Social services will be consulted for a discharge plan, especially if the patient is sent home while still receiving IV antibiotics. In Brad's case, I would also refer him to community resources for a substance abuse and living situation. I would recommend a rehab and recovery program and facilitate access to a patient teaching should include the importance of medication regimen adherence, sufficient fluid intake, a low-sodium diet if heart failure is present. Activity is tolerated based on the severity of their illness, but take frequent rest periods as needed. Wash hands to prevent infection, avoid crowded areas to reduce the risk of infection, practice good oral hygiene, and advise all providers, including dentists, of your history of endocarditis so that antibiotic prophylaxis can be prescribed if needed. The objective of treatment for infective endocarditis is to eradicate invading organisms through adequate doses of an appropriate antibiotic. Human flourishing is exhibited when the infective organism is eliminated and the patient begins to feel better, regain an appetite, and have less fatigue.